and your lecture is going to add to the prestige of MAPICON 2024. Thank you very much.
Thank you, Dr. Vitull, for such a humble and nice introduction. And I thank the organizing committee for giving me an opportunity to be here. So this is the topic actually chosen by Dr. Vitull only, that I have to talk about sudden cardiac death, the perspective in 21st century. The reason being that we have in the last few years, we have seen, especially after the COVID, we have seen that a lot of young people are dying suddenly at home. So this might be the thing in Dr. Vitull's mind, and he told me that you have to talk on this topic. So when we talk about the concept of sudden cardiac death, it started back 120 years ago, and it was Dr. John A. Macmillan who introduced this term. And when we talk about the definition of sudden cardiac death, it is an unexpected natural death which occurs within 1 hour if the death is witnessed. But if the death is not witnessed, then we take this time period as the 24 hours. So each one of us know these personalities. This is just the tip of an iceberg. And one of these was my favorite, the Siddharth Shukla, who was a Big Boss winner. And actually, after winning the Big Boss next year, he collapsed at home and he died of the sudden cardiac arrest. So the magnitude of the problem when we talk about the epidemiology of sudden cardiac arrest and sudden cardiac death, about 0.1% is the incidence, is the prevalence in the US, and same is in the Europe as well. About 3 million to 4 million deaths occur in a year in US. And when we talk about India, about 7 million deaths occur due to the sudden cardiac arrest every year. So you can see how much prevalent this disease, we can call it a disease, is. The important thing about this sudden cardiac arrest and sudden cardiac death is that though in general population we see that it is 0.1%, but keeping in view the large population, so this sudden cardiac arrest is more commonly seen in the low risk patients. You can see in the if the patient is having a high risk, like the patient is having a myocardial infarction, the number of deaths is more. But when we take into consideration the general population, the absolute number of sudden cardiac deaths is more in the low risk group as compared to being in the high risk group. And unfortunately, we don't have much to preempt whether the person in a low risk in the general population is going to have the sudden cardiac arrest. These are the general routine risk factors: the older age, the male gender, the race, obesity, cardiometabolic risk factors. These are the risk factors what we assess in the general population and come to the conclusion whether the patient is going to have the sudden cardiac arrest in future or not. The only good thing about these risk factors is that these risk factors, they only identify the people who are at risk of developing the structural heart disease. That is, these risk factors are only there to find out whether the patient is having a high risk of developing the myocardial infarction or the coronary artery disease. So we don't have much to give to the general population as far as the sudden cardiac. The exercises, they are doing the treadmill and there's a certain collapse on the treadmill. So there is a role of activity. So it is recommended that once we are doing more exercises, the chances of having the sudden cardiac arrest is more as compared to having the moderate exercises. If we talk about the annual incidence of cardiac deaths during the exercises, 1 in 2 to 3 million. But in cardiac rehabilitation programs and the stress testings, the 6 times higher if we are doing the exercises. So these are the other risk factors what we have for the coronary artery disease: the age, hypertension, intraventricular conduction blocks, the dyslipidemia, the diabetes, smoking, and the obesity. These are the risk factors. The only thing is that more the number of the risk factors, the more are the chances of having the certain cardiac arrest. So if a person has only a single risk factor, the chance of certain cardiac arrest is less. But if the number of risk factors is more, the chance of cardiac arrest is more. So causes of sudden cardiac arrest, about 70% of the patients, they have a coronary artery disease, and the cardiomyopathies, they form the second most common, and rest of the 2 to 3% of the patients, they have an inherited arrhythmia or the valvular heart diseases. So when we come to the causes of the sudden cardiac arrest, we usually divide the patients into two groups based on the age. If the age is less than 35, the chances of sudden cardiac arrest due to the cardiomyopathy is more, and when the age is more than 35, the chance of cardiac arrest due to the coronary artery diseases is more. So depending upon the age of the patients, we can just make an assessment whether this patient has a familial cardiomyopathy or is having an idiopathic or the coronary anomalies, or if the patient is having a coronary artery disease. But as we are seeing, number of patients who are coming with the coronary artery disease are younger in age, so maybe in future this classification may not be applicable for the certain cardiac arrests. So this is again showing the same thing, where you can see that the genetic diseases and the congenital diseases are more common in the younger age groups. In the middle age group, it is the cardiomyopathies, especially the hypertrophic cardiomyopathy, and in the age more than 35 or 50 years, it is the coronary artery disease or the heart failure patients who are more prone to have these certain cardiac arrests. So in the disease states, the coronary artery disease, it is the commonest. About 80% of the patients of the coronary artery disease, they have the sudden cardiac arrests. And it has been seen in one of the nationwide study that there are 13% of all first MIs present with the out-of-hospital cardiac arrest. So you can see that coronary artery disease can be, the first presentation of coronary artery disease can be a certain cardiac arrest. So there are two major scenarios of certain cardiac arrest in case of an acute setting, in case of a chronic ischemic heart disease, and the two parameters which are important in suggesting whether the patient is going to have a certain cardiac arrest is the ejection fraction and the premature ventricular contractions. But as we have started understanding the ejection fraction better, we have seen that these risk factors, they are not applicable for the certain cardiac arrest, because we have seen that even in the patients who have a less ejection fraction, they may have the mortality may be higher, but the incidence of certain cardiac arrest is less as compared to the patients who have a preserved or reserved ejection fraction. So on the basis of clinical history, the following four variables, they should be kept in consideration when the patient of a coronary artery disease or an acute coronary setting comes. If the patient gives a history that he has a syncope at the time of chest pain, if he is in an NYHA class 3 or 4, if he has documented ventricular tachycardia or fibrillation early after myocardial infarction between 3 days to 2 months, and there is a history of previous myocardial infarction. So if you find these four variables in a patient of coronary artery disease, so these are the patients who are more prone to go for the certain cardiac arrests. Similar to the cardiomyopathy, the second leading cause, about 2 to 4% is an incidence of certain cardiac arrest in these patients. It is a heterogeneous variety, so some cardiomyopathy patients who have an ejection fraction of 20%, 15%, they live longer. Some with an ejection fraction of 25, 30, they have a certain cardiac arrest. So it is a heterogeneous variety, so some genetic mutations or the genetic variants come into the play at that point of time. And the various non-invasive parameters they use for risk stratification, or if you find the non-sustained VT on the Holter, if you find the T-wave alternance, late potentials, heart rate variability, or the other autonomic associations. The hypertrophic cardiomyopathy, it is more commonly seen in males in the middle age groups, and the patients with hypertrophic cardiomyopathy who have a history of syncope in the past, who have a sustained ventricular tachycardia, family history of certain cardiac deaths, diverse genotype, recurrent syncope, multiple episodes of non-sustained ventricular tachycardia, they are the strongest risk factors for the certain cardiac deaths. The other thing is when we go for the genetic study in these patients, the mutations in the alpha-tropomyosin and the beta-myosin heavy chain gene has been found to be associated with the certain cardiac arrest in these patients. So a couple of points about the arrhythmogenic right ventricular dysplasia. It is again one of the congenital diseases where the muscle is replaced by the fatty or the fibrofatty tissue in the right ventricle, and in 1/3 of the cases in the left ventricle as well. So we can get in these patients we get an idea from an ECG only. Similarly, There are a couple of points about the arrhythmic mitral valve prolapse. No, mitral valve prolapse was considered as one of the benign things, but nowadays it has been seen that if you are not able to find the cause of certain cardiac arrest in a patient, then on echo you find a mitral valve prolapse, then look for the risk factors for certain death in these patients. If the patient has syncope, non-sustained VT, presence of mitral inner disjunction, late gadolinium enhancement on the MRI, and the reduced ejection fraction T-wave inversions. If you find these parameters in a patient of documented mitral valve prolapse and a patient has a syncope, then keep in mind that these patients may land into the sudden cardiac arrest. So only 1 to 2% of these patients, the primary electrophysiological abnormalities, they are especially seen in the young patients, and they represent an electrical, imbalance, and they structurally and mechanically the heart is normal. The only problem is in the channelopathies. So these are the patients or the children who have a congenital long QT syndrome, WPW syndrome, idiopathic ventricular fibrillations, Brugada syndrome, CPVT. These are all the, but this group of patients is only 1 to 2%. So we should, and these are mostly seen in the young, the children less than 20 years of age. So you should keep into consideration elderly patients. The chance of these things are very less. The only thing is that the long QT syndrome can be seen in the older patients, especially when the patient is taking some medications as well. Regarding the congenital long QT syndrome, there are a number of subtypes of QT syndromes. The only thing worth mention is that the incidence of cardiac events is higher in long QT 1 and 2 than in the long QT 3, whereas the lethality of cardiac events is higher in the long QT 3 than in long QT 1 and 2. So this is diagnosed on the genetic study. So there is a genetic panel available for diagnosing these subgroups. So WPW, this is again an ECG abnormality you can find. The incidence is cardiac death is about less than 1 per 1,000 patient years. Similarly, Brugada syndrome, you can see on the ECG, you can find it or give a provocative medications and find it on the ECG as well. I have seen in my lifetime only one patient of Brugada. That patient was from Italy, and we inserted an AICD. Once she was operated for some abdominal problem, and ultimately she had a recurrent and refractory VT. So we diagnosed her on the ECG, and we had put an AICD long time back, about 7 years back. She is doing well. So the mechanism of the sudden cardiac arrest needs a structural or anatomical abnormality. The transient risk factors come in between, and then the arrhythmia comes. So this is in the nutshell what happens in the sudden cardiac arrest. We have a mechanical or a structural defect in the heart, some transient risk factor comes in between, and the patient develops arrhythmia and the sudden cardiac arrest. So these are the tests used for risk stratification. I don't want to go deep into this. The only thing is which has come in a long way nowadays is the looking for the coronary artery calcium by doing the CT angiography. So it is one of the robust midterm predictor of poor outcomes than other cardiovascular risk factors. So apart from the ECG, echocardiography, MRI, the CT angio has also come up and in a big way in these high-risk patients. As far as the treatment, none of the antiarrhythmic medications, they are effective in the certain cardiac arrests, especially. In fact, there are various classes 1 drug, class 3 and calcium antagonists. They in fact increase the incidence of the arrhythmias. The only antiarrhythmic medications which have been effective in reducing or in subsiding the arrhythmias, the beta blockers and the amiodarone. The rest of the medications we don't, the rest of the antiarrhythmic medications we don't have. But now we have the IGLT2 inhibitors, the ACE inhibitors used in the heart failure patients, ARNI. So they are more or less very much effective in the arrhythmia patients and reducing the arrhythmias. So once the patient has suffered a cardiac arrest, so this is the treatment algorithm given for them. The only point I want to mention here is that there is a role of an AICD, that's a cardiovascular defibrillator. So this is what we have till date as far as the sudden cardiac arrest is concerned and its management is concerned. So what is the envisioning near-term sudden cardiac death prevention in 21st century? So there is a call for changing the paradigm of sudden cardiac death prevention, because ejection fraction, which was once considered as one of the tools for the patients at a high risk of developing a certain cardiac arrest, it has been seen that only 1/3 of the patients who have an ejection fraction less than 35, they go into the sudden cardiac arrests. So there are competing risks which are not being considered right now. There are absence of the risk factors or the risk scores actually in the general population. The ICD complications are there, and the certain cardiac death risk is dynamic. So these are the three things which need to be evaluated, or which are the current, which are currently being focused upon: the competing risks, the risk factors in the general population, and the dynamicity. So a new approach to sudden cardiac death. We have been talking about the sudden cardiac death, but the paradox in the 21st century is that it is not sudden, because it has been seen that about half of the patients who have a sudden cardiac arrest, they have some warning symptoms. So what we are talking about, the sudden in the last 10, 12 minutes, in fact, we are paradoxically negating that. So these warning symptoms, one should be very aware, and one should be very knowledgeable to understand those warning symptoms. And it has been seen, if a person is able to understand these warning symptoms, the chances of survival is increased by 7-folds. So some transient risk factors, we have been talking about the stable risk factor as far as the age, hypertension, diabetes is concerned, but it has been seen that only 20% of patients who survive the cardiac arrest develop features of transmural myocardial infarction, and 50% of deaths in heart failure patients are sudden, even in NYHA class 1 and 2. So this probably relates that some transient thing occurs in between, and it leads to the sudden cardiac arrest. The transient thing can be in the form of myocardial ischemia, maybe a spasm for some time, hemodynamic dysfunction, abnormalities in the electrolytes. We see that hypokalemia, hypomagnesemia, it creates a problem. Change in the pH or PO2, and influence of the central and peripheral autonomic neuropathy. So these transient risk factors should be kept into consideration and should be evaluated or thought upon in these patients. The other thing is that what we have been doing till date is we have been reading and understanding the static ECG. The static ECG, it reflects a one-time electrical status. But what we need to understand and what we need to follow is the dynamic monitoring. So dynamic monitoring can help us in understanding the transient risk factors. Especially we have the Holters nowadays, which can read the rhythm, ECG rhythm, 10 minutes and 10 minutes before and 10 minutes after the episode, and we can understand the dynamic monitoring in the form of J-point amplitude. If there's an increase in the J-point amplitude, the chance of certain cardiac arrests are more. So they can assess these patients at least 1 hour. The studies have shown that they can assess these patients who are prone to develop the certain cardiac arrest 1 hour before the episode. So dynamic monitoring is another field where we should focus upon. So when we come to the 21st century, the real risk time acute risk stratification, we have to use our devices. This is the certain cardiac death prevention. Once the patient develops the symptoms, or he feels that something is not going well in my way, he can start using his connecting devices, be it the smartwatches, be it the mobile phones, and then the data will be captured and it will be acquired by the device, then diagnosis of certain cardiac arrest, then the continuous data analysis will be done, use of an artificial intelligence, and then ultimately the patient will develop we will be able to understand with the high-risk patients. So in the 21st century, when we talk about the envisioning of 21st century, the combination of the warning symptoms, connected devices, and artificial intelligence will make near-term prevention effective in reducing certain cardiac death burden in near future. And this strategy will improve the certain cardiac death prediction, reduce delay for resuscitation, decrease delay for medical contact, and improve referral to the appropriate level of healthcare expertise. So in a nutshell, of all presentations of the cardiovascular disease, certain cardiac death is the most challenging and feared. It may strike without any warning in previously apparently healthy individuals and results in tragic events for those left behind. Despite major advancements and investments by the Medical Research Committee over the past decade, the prognosis of out-of-hospital cardiac arrest countries continues to remain dismal, with the highest reported overall 30-day survival of only 13%. More work needs to be done on transient risk factors and near-term prevention using the concept of dynamic monitoring. In this regard, artificial intelligence, machine learning have the potential to play an important role in arrhythmia diagnosis and prediction. And in the near future, one can imagine that connected devices such as smartwatches will continuously monitor the at-risk patients and automatically detect sudden cardiac arrest by utilizing key parameters such as heart rate and oxygen saturation and by detecting the absence of physical movement. And this is all possible when we are able to penetrate deeper into the society and make everybody and each one aware about this dreadful disease. Thank you very much.
Thank you very much, Dr. Suri. You have given the overview of the serious condition which daily we are seeing on social media, that this young person has collapsed on road, collapsed in gym. So we need to be careful, and as rightly said, that all the high-risk populations should get their profile done so that sudden cardiac death can be prevented, or at least we can save some people. Thank you very much.
Any questions?
You are being watched online by a lot of people, but we don't have any, communication with them. So thank you very much.
Thank you, sir, for this amazing presentation. And it's my pleasure to introduce Dr. Bhupender Singh, Additional Professor and Head, Department of Cardiology at AIIMS Bathinda, for a presentation on topic Heart Failure with Preserved Ejection Fraction Evolving Trends.